Good afternoon, Dr. Kofi.
Good afternoon.
Great to see you.
You as well.
All right, I see the number is going up. Just to respect everyone's time, it is 2 minutes after 2 p.m. We are going to go ahead and get started. Good afternoon, everyone. My name is Yolette Gray. I am the Director of Public Policy and Community Engagement at the DC Hospital Association. Welcome to this afternoon webinar being provided under one of the association's program, the Healthy Hospital Initiative. Food as Medicine, a Whole Health Strategy. Dr. Kofi Essel will delve into food as medicine in healthcare settings, strategies to seamlessly incorporate food as medicine within complex health systems, and explore real-world examples of food as medicine within the DC region. Dr. Essel is the Food as Medicine Program Director at Elevance Health, a member of the Health Outcomes Organization team where he coordinates broader social impact strategies and initiatives. In addition to being a board-certified community pediatrician at Children's National and clinical associate professor of pediatrics at the George Washington University School of Medicine and Health Sciences, Dr. Essel recently served as the director of the GWU Culinary Medicine Program. His career is dedicated to healthcare advocacy and research, particularly in addressing diet-related chronic diseases and food insecurity. Please help me welcome Dr. Kofi Essel. Dr. Kofi, the floor is yours.
Awesome. Okay, I'm gonna go ahead and share my screen and get started. All right, I'm excited to be here to talk about this topic today. I want to spend maybe the next, 40, 45 minutes in discussion and hopefully leave enough time at the end if I don't overtalk in sharing this exciting topic. This topic is one that has garnered a ton of attention of late, and everybody's trying to position themselves to understand what it is and really make sure they're not behind the 8 ball in terms of being able to provide services to patients, members, families that could ultimately optimize health in a way that is quite meaningful. So let's go ahead and dive on in. I'm going to give my title one more time: Food as Medicine, a Whole Health Strategy. I look forward to sharing more with you all. So first and foremost, I have nothing to disclose. A few learning objectives that we'll cover today. Number 1, we'll define food as medicine within healthcare settings. Number 2, we'll discuss strategies to incorporate food as medicine within health systems. And lastly, number 3, we'll describe examples of food as medicine within the DC region. So to start off, I always have to start off with a little bit of a picture. Here's me as a pediatrician, community pediatrician. My training, all of my medical training came out of DC, and I work out of Anacostia. So this is me seeing a wonderful patient and family here. And one of the things that I do in engaging my patients between the age of 0 to 18, or actually 21, one of the things that I do is incorporate a lot of nutrition education. I talk about this topic a lot in the counseling and education with my families. And you may say, well, why do you spend so much time talking about that? Are you really equipped to talk about that? And of course, a lot of you may say, of course he's equipped. He's a doctor. Doctors learn about all these things. Here's the reality of what I know, what I've learned over the years. When I first started, this is me day one of medical school. When I first started medical school, I thought I would have to put my interest in food and nutrition to the side. Why? Because I heard that doctors don't really incorporate food and nutrition into the work that they do. And I heard there's not much training in nutrition education to be able to do it. You can see me here with a bottle of water because from day one, I was about water. So this was an important aspect for me. Now, the reality was starting this area, not knowing how to really incorporate food and nutrition, not thinking that I could, was something that really bothered me. When you look at this groundbreaking report in 1985 from the National Academies, it said something quite interesting. The National Academies did an analysis of medical schools all around the country, and they found a few things to stand out. Number 1, they stated this: the committee concluded that nutrition education programs in U.S. medical schools are largely inadequate to meet the present and future demands of the medical profession. This is in 1985. They also suggested that we have at least 25 to 30 hours in medical school curricula around nutrition education. At baseline, 25 to 30 hours. Now, one would argue over the years, we must have gotten better since 1985. So what do we see most recently? The most recent data is quite interesting. Most recent data said that when we looked at medical schools all around the country, what did we see? The vast majority of schools, 71% of schools, failed to meet even the minimum number of 25 hours. In fact, a third of these schools don't even meet half of those number of hours. In fact, we know across the board that nutrition education in medical school is quite limited. We don't talk about this enough. Providers aren't being educated on this enough as medical students. But what about when they leave and become residents and fellows and practicing providers? They must feel more prepared to talk about this. The reality is the data is quite clear as well. Practicing providers, residents, fellows, they all don't feel prepared to engage this important topic. So how do we lean forward and address these topics if we're not really equipped to be able to do it? Now, one would argue we are all experts in food and nutrition, right? Because we've all had our own lived experiences. And I would argue that's probably the lens in which you may see people speak from. I have my experiences as a child. I know healthy eating from watching these different shows. I know what's worked for my own body, so this should work for you all. Unfortunately, that approach is oftentimes very stigmatizing, very off-putting, and doesn't learn how to meet our families where they are. Why is this so important? Why is this so important that we understand this and that doctors talk about this stuff more? Well, let me first start by saying it's important that doctors know about this topic, but I'm not saying the goal is for doctors to become RDs, right? RDs are RDs, and registered dietitians are phenomenal at what they do. Registered dietitians, community health workers, nutritionists, a lot of these groups are trained to do this incredibly well and actually have a carved out time to be able to do that. Doctors don't have the time, but what we can do is worsen the health of families when we provide information that's very stigmatizing and off-putting. So what I would say is that the angle should be to do no harm and actually align with our colleagues who are also providing high quality education to our families. This requires us to know some education, some information about this topic, enough to be dangerous at least. But I would argue that our training hasn't really equipped us to be able to do that well enough just yet. So why is this so important? When we look around the country, let's look at some of the data that really helps us to understand the concepts that we have here. Looking around the country and looking at chronic diseases, let's say diet-related chronic conditions, for US adults, how many US adults, or what percentage of US adults have at least one diet-related chronic condition? You may say, I don't know, 30%, 1 in 3, or 20%. The answer is actually 60%. More than 1 in 2 US adults have at least one diet-related chronic condition. What about 2 or more? The answer is 40%. So almost 1 in 2 have at least 2 or more diet-related chronic conditions. This is an issue. I spend a lot of time in community settings and we talk about these topics around diabetes and hypertension management. And I talk to different community setting individuals, members, and they tell me, like, this is just the fate of my life. I know I'm going to get these conditions. The reality is this doesn't have to be their fate, and it doesn't have to be the majority of individuals in this country's fate. But what are we doing to support individuals in either preventing, managing, or treating disease? And can food be a viable tool in being able to do that? That's what I'm here to talk about today. Let's hone in specifically on a few diet-related chronic conditions. I'm going to start off with hypertension. We all talk about hypertension. What are the rates of hypertension in this country? 1 in 2 US adults has hypertension. 2 people look in a room, you look at the person next to you, one of the 2 of us has hypertension. What about pre-diabetes or diabetes? It must be better. 1 in 2 US adults has pre-diabetes or diabetes. Is this our fate? Does this have to be our fate? This is an issue that we're seeing time and time again. What about overweight or obesity? 3 out of 4 adults have overweight or obesity. This is also costing our healthcare system a ton of money as well. The Rockefeller Foundation and Tufts did an important analysis looking at the cost of these conditions on our healthcare system. And the number tabulated up to over $1 trillion annually as a result of these conditions on our healthcare system. So it's expensive for us to not do anything, or actually to do what we continue to do and expect different results. So what else do we know about this? When you look at a variety of risk factors that lead to death, what are the top risk factors that lead to death in this country? You can see here on this slide, the risk factors on the left side. The number one top risk factor that leads to early death is poor nutrition and poor diet. Poor nutrition, poor diet is the leading risk factor to death. If you look at this slide and look at this study, under this image, there's another image that looks at morbidity or decreasing one's quality of life. Poor diet, poor nutrition is a leading risk factor for worsening one's quality of life as well. So we see all these things and we say, well, what are we doing about it? So one of the opportunities I've had over the years is I've gotten a chance to spend time as the director of a culinary medicine program at George Washington University School of Medicine and Health Sciences. I got to work with a dynamic team, Dr. Tim Harlan, who came out of New Orleans at Tulane and came up here and planted and has created a wonderful initiative around the country. But I got to work with this team. I was the director at our site at GW, and I advocated for years to get nutrition and education in medical sciences. And I finally was given a chance to lead this movement in a way that I couldn't turn away from. I got to teach medical students. I got to teach faculty. I got to teach community members. These were opportunities that I couldn't pass up, and it was great. And through this opportunity, I learned something really interesting. I learned how deeply tied, and I knew this before, but it just drove this point home, how deeply tied we all are to our experiences around food. One of the things I got a chance to do was talk about phytonutrients. And for you all who don't know what phytonutrients are, phyto for plant nutrients. We need to have phytonutrients in our diet, a variety of different kinds of phytonutrients. How do we know we're getting a variety? Well, one of the ways we know is by eating the rainbow, tasting the rainbow, eating a variety of different colors for fruits and vegetables and whole grains. And we know that these foods are beneficial to our bodies. We know that these foods are incredibly beneficial to our microbiome in our gut. This eating the rainbow concept was really important. One of the other things I got a chance to do was during this curriculum and this course that I used to do each year, I would take my medical students and I would go into the grocery store and I would say, hey, go down the grocery store aisle, the cereal aisle, and pick your favorite cereal and let's learn how to read a food label. Because with culinary medicine, the important thing is not only how you can teach yourself important skills for incorporating healthy eating for your own life, but then how do you talk about this to others as well? So as they went down the cereal aisle, they looked at different cereals that they wanted to pick and cereals that they eat, and they picked their favorite cereal and they started reading the labels. And I began to see this experience of me talking about phytonutrients come to life. As I talked about eating the rainbow, I saw that they were eating a different kind of rainbow. This different kind of rainbow was quite surprising to me. These 20 and 30-year-olds, I'm like, why are you still eating this? But inevitably, it came down to the very important fact. Dr. Kofi, when I was a child, I remember sitting around the table with my grandmother and food. This is what we did together. We ate together. I remember the smells of that cereal. I remember the smell of that environment. I remember the smell of my grandmother, my grandfather. These are the things that tie us so closely to food. We have to recognize that food is far more than health. Food is culture. Food is tradition. Food is family. Food ties us together. I've seen food play a huge role in bringing people together from far and wide for many, many years. I love how this one study talks about food. There are many aspects we can understand and domains we can understand about food. Food can be moral. Food can be aesthetic, right? The way food looks is important to some of us. Food can be social, bringing us together. Food can be sacred or spiritual. And also food can be health. We have to understand the holistic nature of food. This is not a concept that we're talking about where it's just eat this, not that. It can't be that simple. So a few months ago, about 7 months ago, I transitioned to a new role. I'm still faculty at GW. I'm still a provider at Children's National, but a new role. I went over to an organization called Elevance Health. Locally in DC, we're called the Mayor Group DC. And this organization has been phenomenal because it's a large payer and it gives me a chance to take all this work we were doing on the ground, from our research to our advocacy to our dissemination of high quality research, to now scaling this work up to a population level that we couldn't turn back from. This population level allows us to work within commercial, Medicaid, and Medicare to address diet-related chronic conditions in a very unique way using food as a unique tool. I became this inaugural position known as the Food as Medicine Director at Elevance Health. So I'll talk a little bit more about that. But of course, a few of you all may be saying, well, what the heck is food as medicine? What does that really mean? And I think that's a really important question. And let's start there. Food as medicine. Food as medicine, these are strategies or interventions that are working alongside healthcare, that are giving access to high quality foods, primarily focused on prevention, management, or treatment of disease. We center health equity. We prioritize high quality education as well. This is how we define food as medicine. For the people in the back of the Zoom room, I want to say it one more time. Food as medicine, these are strategies or interventions that work alongside healthcare, that give access to high quality foods, good nutritious foods, that are primarily focused on prevention, management, or treatment of disease. Let me not even mention, it could even put diseases into remission. We don't talk about that enough, but let me just say that's something else we can talk about with this concept of food as medicine. Now, with food as medicine, many of you all have heard this topic. Some of you haven't, but let me introduce you to the food as medicine pyramid. This food as medicine pyramid is a pyramid, a framework that we often use when we talk about this concept of food as medicine. On the left side of this pyramid, what you can see is that these are strategies that focus on prevention. At the base of this pyramid, to the top or the peak of the pyramid, focus on treatment. Everybody's heard of medically tailored meals, and I'll dive into that, but these are going to be the most expensive but precise ways in which we can be very direct in addressing specific conditions. So let's start at the base of this pyramid. At the base of this pyramid, we have prevention strategies, population level healthy food policies and programs. And I will say DC is a huge leader in moving forward a lot of strong policies and programs and community level interventions that address diet-related chronic conditions. So what do I mean by that? So we've talked about a few different ways, but food policy councils, some communities and states and cohorts use sugar taxes or nutrition equity taxes, and different approaches like that have been used as well to really transform what things our individuals, members, patients, and families are able to consume at a price that's meaningful to them. The next category we have are, actually I should also say at the population level, we shouldn't forget about our food banks, our food pantries, our soup kitchens, right? Our organizations that are doing this work phenomenally well, right? We have our Capital Area Food Bank in DC. We have groups like Food and Friends. We have groups like all kinds of phenomenal groups, not to get into all the weeds there, but a lot of groups are doing some great work. DC Central Kitchen, I can keep throwing out names, but you all know who you are in the crowd. You're doing great work in the city. Population level healthy food policies and programs are a critical piece of the food as medicine intervention cohort or scope of work. The next category we would talk about are government nutrition security programs. These programs are quite impactful as well. These are our federal nutrition programs like our WIC, our SNAP, our school meals programs. These programs can be quite impactful in improving health outcomes. They can support local economies incredibly well. And also at the end of the day, we can see them decrease costs of care as well. These programs can be really beneficial in improving health outcomes, reducing hospital readmissions. I mean, the list goes on and on. We've seen how these programs can be really impactful as well. So don't forget about our federal nutrition programs. These top three here we'll spend some more time on, but produce prescriptions, medically tailored, what I'll call groceries, and then medically tailored meals. And the last area that I don't think we spend enough time on is high quality nutrition, counseling, and education as well, which can be an important element to providing and combining what we do in food as medicine. Food as medicine by itself, it's not just food, it's also, again, combining high quality education. So let's focus on the top part of this pyramid. We'll focus on these top three. Let's start with this area called medically tailored meals. Medically tailored meals, one of the organizations that does this incredibly well locally is Food and Friends. So with Food and Friends, what do we know about the idea of medically tailored meals? Medically tailored meals provides pre-prepared meals that can be frozen or refrigerator friendly, and basically they're ready to heat and eat. They're designed by a chef and a dietitian to provide more than 50% of the calories for the day, and they're delivered to the home of individuals. These meals can be designed to optimize health in a variety of ways. Individuals who've had a recent surgery or admission to the hospital and can't ambulate or walk well to go to the grocery store or cook, we can deliver meals to the home. These meals can be designed to be tasty, flavorful, and also nutritious as well. And guess what? That reduces the likelihood for readmission as well, or returning to the emergency room. So these kind of interventions have been quite impactful as well. And again, chef dietitian prepares them, designs them, and can be quite effective. They're very expensive because they're pre-prepared, but a great solution for individuals as well. The next category are medically tailored groceries. This is not just fruits and vegetables. These are fruits and vegetables, but other items as well. Whole grains, nuts, seeds, legumes, other items that are part of maybe even a meal kit. It gives you a little bit more autonomy to design and create solutions that really meet the members' cultural preferences as well. Even though medically tailored meals can do that, you get more autonomy with medically tailored groceries. It's also a cheaper option. But again, you're hoping to take advantage in this place of individuals who can prepare their meals. It's a good activation step, especially when you're thinking about the long-term sustainability of food as medicine programs. And then lastly, we'll put in this category produce prescriptions. This doesn't just have to be, and this is fruits and vegetables. It doesn't just have to be fresh. It can be frozen, it can be canned, but fruits and vegetables are an important element of this puzzle as well. Why is that? When you look around the country, and we talked about US adults, but in terms of US adults consuming enough fruits and vegetables, I usually ask my students all the time, how many adults consume enough fruits and vegetables? And they say, 1 in 5, 1 in 3. 1 in 10 US adults consumes enough fruits and vegetables. 1 in 10 US children consumes enough fruits and veggies. The cycle continues over and over. Our microbiome is depleted. We walk around constipated and bloated, and we're not getting the benefits from these rich foods that could be impacting our health for a variety of reasons, and we can get into that. But in general, these are also going to be a cheaper intervention, but quite impactful in improving overall health as well. When you look at the data across the board, there's still a lot of questions we have about food as medicine. The right dosing to use, how much should we be using? How long should we be using some of these? Should we be combining programs? There are questions we have to ask ourselves for sure, and we continue to do more research on them, but there's a lot we already know. Some of the data we know about the effectiveness of food, we know about the effectiveness of medical nutrition therapy, nutrition education. But what about when we combine these together? The data is quite clear. We see clear associations with ED visits, hospital readmissions, improving dietary intake, blood pressure changes, A1C changes, which is a diabetes measure, overall health status, mental health risk. We also see many, many more things as well. The list goes on and on and on. You're seeing new studies come out about this all the time. Stay alert, be kind of insightful about what you're seeing here, because we are seeing a ton of good evidence here. Now, I want to take a pause here. And as a provider who practices evidence-based medicine, one of the things that we have to look at is the evidence. Well, what does the evidence say about food? If you look at a variety of different evidence-based guidelines from professional organizations all around the country addressing different diet-related chronic conditions, diabetes, heart disease, obesity, non-alcoholic fatty liver disease, the list goes on and on. What is one of the first things that are recommended to use as an intervention tool for families? One of the first things that's recommended is food and lifestyle. Unfortunately, we don't give food the chance it deserves. One, we're not trained well on it. So how can we believe in it if we're not trained well on it? We don't know the science of it. We don't know the effectiveness of it. We haven't looked at the data. And two, how do we do this if we don't have the time or the capacity or the know-how to incorporate into medicine? We have to think about this through a paradigm shift. This is not just about training doctors to do this or nurses to do this, even though that's helpful and beneficial. It's about shifting the paradigm. And that's where food as medicine comes in. I don't want you to believe that this is simply just saying, eat better, eat more fruits and vegetables, just do this and everything will be fine. It's not that simple. In fact, the way we think about this at the Mayor Group DC is we use a whole health lens. A whole health lens is critical to how we approach this topic. And the question, of course, is what is whole health? You've seen an image like this before. We take it that the majority of the experiences, the health outcomes of our members and individuals, families, and patients, their outcomes are not the full result of what's happening in the four walls of the clinical space. The four walls of the clinical space are critically important. They impact the health of the patient. However, it doesn't tell you the whole story. We believe we're uniquely positioned by understanding the experiences, the lived experiences of our families, in a way that then we can uniquely respond with meaningful interventions to support them and support their whole health. One of the reasons I transitioned over to this role, in addition to population health and be able to really address this topic in a unique way, was because of the bold purpose of improving the health of humanity through this whole health lens. And when we think about whole health, people typically think about one aspect in particular with food as medicine, and that's what? Food insecurity. Food insecurity is the lens that we think about. And what is food insecurity? Food insecurity is when all members in a household don't have access to enough foods to live an active and healthy lifestyle. When all members in the household don't have consistent access to enough foods to live an active and healthy lifestyle. Most people will call this hunger, although they're technically different. Let's not get in the weeds, but it's fine to understand it as hunger for our conversation today. Food insecurity is quite prevalent. It's quite important to understand. And there are a few things that I think are important to recognize about food insecurity. When we think about this topic, I want to frame it for you. I work with families throughout the year that experience food insecurity. When a family has a sudden financial hardship, a sudden challenge around finances due to a job loss, changes in hours at work, or whatever it may be, a sickness in the home. There could be 1,000 things that could trigger this. What ends up happening? Well, the food budget is the first thing to change. Why is that? Because the food budget is so flexible for families. It's so fungible. So you'll see people tend to change that food budget first as the first thing to go. So when you think about a variety of health-related social needs or social drivers of health, when you think about how you address them or if you should address them, where you should start, food oftentimes is a great area to start because it's one of the first things to drop. Now, when we talk to families around the country, what do we learn? The first thing that families describe is this concept of food anxiety, a constant preoccupation, perseveration with where one's next meal is going to come from. Where is this next meal going to come from? How am I going to provide for my family? One of the ways we often describe this is it decreases our cognitive bandwidth. Our ability to shift and focus on many things becomes hindered because of this toxic, impalpable stress on our bodies, on our brains, on our minds. So think about that parent that's struggling to plan ahead. You're telling them meal plan 2 weeks in advance, and they're struggling to do that because of these toxic stresses that really impedes our thinking at times. So that's the first coping mechanism that happens. The next coping mechanism that happens is, of course, the quality of food begins to drop. I call this the monotony of the diet. The diet becomes very simplified. We tend to eat the same foods over and over again. The purchasing of fruits and vegetables happens less. Why? Because if I purchase those fruits and veggies, are these children going to eat it? If I purchase these fruits and vegetables, am I going to eat it? Is this food going to go bad? If it goes bad, this stress that goes along with that is really significant. And it's hard for me because that stress goes along with this other stress that I have. And wasting money is something I can't do right now. So the variety of food begins to decrease. People get the same foods over and over again. The desirability begins to decrease. They tend to purchase foods that we call ultra processed foods, right? Higher in sugar, higher in salt, higher in fat. The brain releases dopamine when it consumes this food. The whole industry seems to be pushing us towards these foods because when we consume them, they feel good. They're cheaper, easier to access. Families consume them, they feel better about themselves. It acts as a pop-off valve for the brain. But at the end of the day, is this supporting the health of individuals? I would say it's not. The next step that happens after the diet becomes more monotonous is the quantity of the diet changing. Some of you all have seen kids, have worked with kids. Some of you all are parents. You've seen what happens. Parents will do everything they can to protect their children. So what's going to happen first? Parents are going to decrease their food intake first. And lastly, the children will decrease their food intake. This is the journey, the lived experiences of families that experience food insecurity. And it's usually a trigger of a financial hardship from some form or fashion. There are 3 important facts I want you to leave with when you understand food insecurity. Because like I mentioned, food is medicine. Typically, the angle people think about is food insecurity, and that's okay. Number 1, food insecurity. We know that there are clear associations with worsening diet-related chronic conditions. You can see here on this chart, food insecurity, households with food insecurity have higher rates of conditions like diabetes, hypertension, heart disease. The list goes on and on and on. Is it chicken or egg? Which one comes first? We're not always clear, but at the end of the day, we see clear associations with these 2 categories, and we know one worsens the other all the time. The second thing we need to understand is food insecurity has a high prevalence. The most recent data on food insecurity came out about 3 months ago. It comes out every year around September, but last year it came out in October. We saw that over the course of a year, food insecurity rates jumped up by about 2 to 3%. So what did we see? Households went from 1 in 10 households to 1 in 8 households around the country experiencing food insecurity. If households have children in them, they went from 1 in 8 households to 1 in 6 households. So prevalence of food insecurity has gone up. We've seen some of the federal mandates sort of be pulled back. We've seen some pullback from some of the investments in the charitable industry as well. So this is what happens as a result of these different movements. We know that some households experience food insecurity much higher than other households. Households experiencing poverty, even up to 185% of the poverty line, single parent households, communities of color, households with children, the list goes on and on. But I don't want you to think that food insecurity only occurs in these households. In fact, I want you to unlearn that food insecurity only occurs in certain households. I want you to learn, in fact, a different concept, that food insecurity is what I would call ubiquitous. Every single county in this country experiences food insecurity. There's not one county that's free of food insecurity. And when you understand that, it changes the game. When I started doing work in this space years ago, I started by screening providers around the country. And I said, hey, providers, are you screening? Are you looking for food insecurity? And what did they say? They said to me, yeah, I screen for food insecurity. Well, when do you look for it? Well, I look for a sign or a symptom. Well, what do you look for? I look for weight loss. That's the thing that I look for. That's the number one thing that I look for. And as I began to do more and more work in this space, I began to learn something. Food insecurity is what I would describe as invisible. We cannot consistently rely upon clinical signs, our physical exam signs, weight gain, weight loss, laboratory changes to be able to consistently or reliably determine if a family is experiencing food insecurity. This is not going to be reliable. In fact, families will present to their workplace, families will present to their clinic spaces like they have it all together because they want to prove to you that don't you worry, everything is fine. In fact, if they have children, they want to make sure that they present their best face because if they, for some reason, show you that there's a challenge in the home, the concern is if this is not a safe space, what if you think I'm neglectful towards my child and then take my child away from me and call CPS or whoever? This is a concern. So this is something that comes up often. We have to understand that it's invisible, but yet at the same time ubiquitous. Are we going to close our eyes and act like it doesn't exist? Or are we going to open our eyes and realize it even occurs in our own backyards, at our workplaces, in our hospitals, in our clinics? It's here. We have to act. The last thing I would describe is that food insecurity is what I would describe as it has an incredible amount of inequities that exist around it. When I first started to understand COVID-19, I used to describe it as what I would say is the great equalizer. I heard about all these stars and famous people getting it, right? So Tom Hanks, right? He was the first actor I heard about. And you heard about prime ministers getting it. And I realized, hey, this is affecting all of us. But then as we started to look more and more into food, into COVID-19, we began to realize something. It actually wasn't the great equalizer, it was the great magnifier. It magnified inequities that had existed for far too long. It was now thrown in our face and said, hey, we need to do something about it. Take a look at this slide here and look at food insecurity data in the first few months, in the beginning of COVID. There is already inequities that existed amongst households before COVID even started. But what happened as a result of COVID? You saw that all households increased their rates of food insecurity, but some households increased more than others. And the magnitude in which they separated was quite significant. Again, magnifying inequities that existed for far too long and said, hey, we need to do something about it. Another reason you're seeing food as medicine really pop to the forefront and move, and the momentum has grown so significantly because we started to see individuals with these diet-related chronic conditions experiencing the worst outcomes. We started to see these long lines of the food pantries and the food banks. We started to see these invisible lines for these federal nutrition programs, and we knew we needed to act. But to improve the health outcomes of individuals, we have to expand our conversation to thinking about the complement to food insecurity. And that's what I would call nutrition insecurity. The USDA brought this term forward a few years ago. This has been an internationally understood term, but we understand it differently in the US. And this is a term that we move forward to really discuss the quality of food, not just the quantity of food that individuals are receiving, but the quality of food. Are individuals getting the right types of food, that are focused on prevention, management, and treatment of disease. So nutrition security brings to the forefront equity, food security, and the quality of food. And this is sort of a newer measure that we're talking about when we think about food as medicine. We think about food insecurity, nutrition insecurity, and diet-related chronic conditions. I have two case studies I have for you to end our dialogue today and leave some time for some Q&A. So case study one, I want to bring back to our discussion this image that I showed you earlier, this image really highlighting the trajectory of experiences of individuals when they experience food insecurity. And I want you to take a look at these pictures and tell me what you see. So I have a picture here. I'm sorry to throw out name brands, but you can see here some Honey Nut Cheerios, blueberry muffin, some sort of whole milk, adding some extra fiber to the whole milk to add a little fiber to the diet. You can see here a croissant, some margarine, some turkey sausage, some blueberry yogurt with some fiber added, again, to add a little bit more fiber to the diet. You can see here some chips, some non-fat Greek yogurt with some fiber added, some diet lemonades, really some Crystal Light with some fiber added. You can see here some sandwiches. And then you can see here's an image of a famous lunch and dinner, chicken tenders and canned green beans, and you have some diet lemonade, again, some fiber added, and mac and cheese, of course, as well. Here's some snack foods, some baked Lay's chips, some peanuts, some goldfish, different things like that as well. Now, you saw those foods. I want you to compare it to these foods here. Here's a spinach salad. You have some apple slices, some bulgur in there. There's some vinaigrette on the side, some grapes. Here's some rice and orange slices, a side salad, a few different things that you can see here. Here's an omelet. You can see spinach. You can see, I believe those are some bananas. You can see a sweet potato hash. Here's some snacks, apples, oranges, some raisins, some nuts. And I want you to ask yourself, what's the difference between these two categories? And I would pause if I were in front of my students and I would call you out, but I don't have time for that. So I'm just going to ask you to think about it. The way I want you to think about this is that they're levels. As the young people would say, there are levels to this topic that you need to understand. Now, the levels to this are a few different things that I would love you to think about. Now, the first level is what we would call unprocessed or minimally processed foods, okay? So you take foods, just because the food is processed doesn't mean it's quote unquote bad. In fact, we go away from using the term bad versus good, I get it. But in general, it doesn't mean it's harmful. Because you take that lettuce and you cut the lettuce up, or the kale or the collards, you cut it up, you put it in a bag, you put it in the grocery store, and you sell that. That's a minimally processed item. So when you look at the classification scale for processed foods, we know that minimally processed or unprocessed foods are in the same category. It's stage one. Not too bad, right? Stage two, we think about processed culinary ingredients. So this takes the salt, the sugar, the vegetable oils, really thinking about the items, taking the items that are used and those culinary ingredients and using those items. That's what we call processed culinary ingredients. Okay, that's stage two. Stage three, you take these processed culinary ingredients, you mix it together, and you take it together with minimally processed or unprocessed foods, and you bring these two together. We call these processed foods. And then the last category we call ultra processed foods. These foods don't really resemble the real food anymore, right? They are added more chemicals to them, other additives to them. They're broken down in a way that they don't resemble the actual food anymore. Now, ultra processed foods tend to be a large part of a lot of our diets. In fact, it's a large part of most of our diets. The majority of people in this country, ultra processed foods are the majority of our diet. Interesting, when you look at the outcomes we also see in this country as well, especially over a course of time. Ultra processed food play a huge role in that. Now let's talk about a study that can be eye-opening. Dr. Kevin Hall at the NIH down the street from us did a phenomenal study looking at ultra processed foods, and here's another definition for you all. But basically he took a group of adults, about 20 adults, and he trapped them in a lab, said, you got to stay in this room, you can't go anywhere. He took 10 of the adults and said, you can have as much unprocessed or minimally processed food as you want for breakfast, lunch, and dinner and snacks. And then other 10 adults and said you can have as much ultra processed food as you want for breakfast, lunch, and dinner and snacks for the whole day for the 14-day period as well. So for 14 days, they said you can have as much as you want for breakfast, lunch, dinner, and snacks. They matched the meals for calories and for nutrients. That's why they were adding, the fiber to the drinks and different things like that. Every meal got to be matched in that way. So the nutrient for nutrient comparison were the same, right? So that's the argument. Like if I'm eating the same nutrients, does it matter? So nutrient for nutrient, they're the same. And then after the 14 days, they crossed them over. The people who were in unprocessed category went to the ultra processed category went to the unprocessed category and said, eat as much as you want for another 14 days. So this study was interesting. And what did we find out? We found out that individuals, when they were in the ultra processed category, they ate 500 calories more each and every day. They didn't feel full with eating these foods. And in fact, that it required them to eat more to feel a sense of fullness. While the people in the unprocessed category, or when they got there, they ate 500 calories less than the ultra-processed food group. So what ended up happening? Individuals in the ultra-processed category gained about 2 to 3 pounds over the course of the 2 weeks. In an unprocessed group, they lost about 2 to 3 pounds as well. One thing we don't often talk about is how much did this food cost? Well, the unprocessed food category costs about $50 more than the ultra-processed food category. Unfortunately, it does feel like the foods that are going to be better for us cost more money to eat and consume. And that's why another reason why people may lean towards foods that are more ultra-processed. Are there things that we can do to support this? There are a variety of things we can do, and we can talk about that moving forward as well. But I wanted you to understand the difference between these two categories. NPR did a really nice expose report on this. And you can see this picture here. I love this picture. You can see here an apple, and you can see a cut apple. All right, this is minimally processed. You cut the apple, you put it in a bag, minimally processed, unprocessed, still stage 1. You take it, you put it in applesauce. Now you're talking about stage 2, stage 3. And now you have an apple pie or an apple gummy bear. Even if this apple gummy bear has 100% vitamin C and extra fiber sprinkled over the top of it, and you can taste the crunch of the extra fiber, it is not real food. It is not food. It is an ultra-processed item that has been genetically, or not genetically, let me not say that, but has been engineered to taste great, to be cost-effective, to be convenient, and to make sure you can't just eat just one, to be hyper-palatable as well. So we have to understand the positioning of these foods. And here's a really good analysis of this. You can look at this study that was published in the BMJ, well, not study, but analysis that was published in the BMJ that really showed the mechanisms of what we think ultra-processed foods are doing to our diet. They're changing our microbiome. They're increasing inflammation in our body. They're worsening our blood sugars. They're worsening our blood pressure. The list goes on and on and on as well. But there's been a ton of studies that's been out in the data that has linked ultra-processed foods to a variety of things: type 2 diabetes, hypertension, heart disease, the list goes on and on again. We're still learning more and more about them. But at the end of the day, the question is, should we be more alert? Should we be thinking about this when we give recommendations, what we're offering in our hospital systems, how we're providing them to our patients? At the end of the day, we have to ask ourselves this very important question: are we as healthcare putting systems in place to worsen the health of our patients and families, or are we using this food as a tool for disease, dis-ease, not to improve, not to heal the body, but are we worsening the health of our patients and families? We have to think about this. What are we doing when we think about the role food plays in our healthcare systems in our region? One of the groups I work with, as I mentioned, out of GW, Culinary Medicine Group has a Health Meets Food national organization, and they actually have a certification for food service providers, because a lot of food service providers will often say, this is something I don't feel skilled in being able to do or equipped to doing. So there's a culinary medicine certification that actually can equip them in building the skill set to be able to then provide and bring those skills to healthcare systems, to hospitals. You're seeing a lot of hospitals around the country starting to really shift what they're providing to the people in the hospital. So they realize they can get more options in there, and that the foods that they're getting are not worsening the health of them just because they're matched. They have calcium that's the same, or vitamin D is the same. we're not giving real food. We're not giving real food. The last case study that I'll mention before I stop is a local intervention that our team was doing out of Children's National. So one of the things that I need you to understand about DC, so I share with you national reports about food insecurity. And those national reports are really helpful to understand. About 12.8% of households in the country experience food insecurity, about 1 in 6 households with children. We get it. The Capital Area Food Bank has led the movement in the DMV region and has done a good analysis of food insecurity in the region. And they do this every year, and they put this out for the last few years. And in this report, they've shared with us what food insecurity looks like with a number of households. They looked at a number of households around the DMV region, and we saw something quite interesting. When you look around the DMV region, you can see that 1 in 3 households, or rather adults, are experiencing food insecurity. Now, you may say that doesn't make any sense. I was going to say stupid, but we shouldn't say that word, right? That doesn't make any sense. And you can argue with the narrative, but they're using a high quality tool, the same tool that the USDA uses. They are asking these questions in a very meaningful way, and they saw what they saw. This is interesting data. It should open our eyes to what we're seeing in our own backyard. You can see the breakdown of how it looks in different parts of the DMV here. You may say, well, this is just an issue of poverty. It's just those who experience poverty. Look here at the quintiles of income for those who experience food insecurity when the Capital Area Food Bank did their analysis. You can see here that a lot of families have way more than what you would consider sort of the baseline amount of income, the national median income for the country. You can say there's something wrong with the data. They must have done something wrong. Okay, you can say that, but understand the national data says the same thing. Food insecurity is not just an issue of poverty. I just want to re-emphasize that. All it takes is one sudden financial hardship for a family to experience these food hardships over the course of the year. MIT has a living wage calculator, and for the DMV region, they said it takes about $124,000 for a family of 4 to cover their basic needs. So again, expand the conversation to how we're thinking about this. 2015, the American Academy of Pediatrics put out a groundbreaking policy statement encouraging providers all around the country, pediatric providers, to screen and intervene to address food insecurity. I became very invested in this work years ago. And as I continue to grow in this work and work with local organizations, a lot of you all in this room right now, I've had a chance to really learn from the best. And from learning from them, I was tapped to lead a movement at Children's National to learn how we can screen and intervene the majority of children in the DMV area, or in the DC area in particular. So I helped to lead a movement to implement a screening and intervening protocol at DC Children's. So we started to do this work, and we did it universally, not just screening individuals who, quote unquote, looked a certain way, but universally screen. Because if you only say just screen sometimes, guess what? That's going to happen. Somebody's going to wait for a certain sign or symptom. They need to be on Medicaid. They need to be on Medicare. They need to have X, Y, and Z. I want to look at how their shoes look. Whatever it is superficially in our brains that we think triggers a food insecurity screening, we'll do that. But instead, if we recognize that this is universal and ubiquitous, we do this in a way that really promotes equity. So we started to do this screening, and it was dynamic what our providers learned. They learned far and wide that food insecurity existed at rates they had no idea about. They said, hey, this family over here, that I would have never guessed that this family experienced food insecurity. With this screening protocol, we implemented an intervention protocol. And initially, low-hanging fruit, created a piece of paper that provided to the families, and they could, be able to then use these tools on the piece of paper, food banks, pantries, local programs that were going on, federal nutrition programs. But what happened to that piece of paper? A lot of you all who do this work on a daily basis know the piece of paper sometimes didn't even make it into the trash can. I was lucky if it made it to the trash can. I see it on the elevator in the parking lot. At the end of the day, this didn't really meet our members and our families where they were in a more meaningful way. And we heard from them, and they said, hey, this is a vulnerable experience for me, and I'm sharing this with you, and you're giving me some resources that some of them are outdated. They don't work. I don't know where to go. It's overwhelming to go through this long list. I know about some of these. And the provider said the same thing. I'm screening for this, and I don't feel like I'm helping them. What am I doing? I'm wasting their time. I'm making them share this information, and I don't have anything for them. How do we do this better? I'm worried about this. So we started doing a little bit more research and understanding what's out there. And I came across this model of a community clinical partnership. This idea of recognizing the role of community organizations that have been doing phenomenal work over the years, are anchors in our local community, and then also recognizing the role of local providers and practices and FQHCs and the work that they've been doing and the connections that they have with their families as well. I said, what does it look like if we bring our worlds together? For years, I was on the ground doing a lot of community cooking classes, one-off interventions, different opportunities like that. And we started to team together with some of the community organizations we were working with. And we said, hey, what would it look like if we created something that's real, that's sustainable, that's long? And we came up with an idea. We said we're going to put the families in the center of everything we do. We're going to have health equity as a core metric. We are going to share information back and forth. We're going to flip the power dynamic. And we ended off with this organization that we call FLIP, the Family Lifestyle Program. We brought together the Children's National, the YMCA in Metropolitan Washington, and the American Heart Association, and developed this community clinical collaborative. And we focus this on healthy families, healthy communities, with our focus being on family-centered care, providing high-quality family-centered care that addresses food and nutrition insecurity and diet-related chronic conditions as well. So we developed a ton of different tools that we have been excited to share, and people are using them locally and throughout the region. And it's been exciting to build these tools and build these different interventions. And we've had a great team. Here's some of our team here that you can see. Some of our funders down at the bottom, and some of our collaborators as well. But we've done some phenomenal work in the DMV area. We also developed a produce prescription initiative where we connected with 4P Foods, a local food hub. And with 4P Foods and this relationship that we had with them, what we ended up doing was they were working with local farmers, providing them meaningful wage, right? Livable wage. They were providing the farmers livable wage and making sure that the farmers we're working with are practicing equitable practices. We're keeping money in the local food system. And that food we were then delivering to the homes of our families who were experiencing food insecurity, nutrition insecurity, or maybe even other challenges as well around diet-related chronic conditions. We also coupled this with nutrition education through community cooking classes ran by American Heart Association and YMCA, in addition to high-quality nutrition education videos that we were sending as well. Recipe cards, everything that they would need. We gave them a toolkit on getting started, sort of a pantry toolkit to get started as well. A lot of different resources, but we did this over the course of 6 to 12 months, getting this food basket every other week for 6 to 12 months. And we heard so many positive things for families. This very notion of families feeling like they can't try new food because if they try new foods and they waste them, that's going to be a hardship. They got to try different fruits and veggies that they eat that they haven't eaten in years, or some of them that they always wanted to try and they didn't because they always felt that they were going to waste them if they didn't eat them. And they started to try them, and guess what? When you try foods over and over again, guess what happens? The privilege of beginning to accept and like these foods. If you have the financial insecurity that doesn't allow you to have the privilege of waste, guess what? You can't enjoy those foods in the same way and benefit off those health benefits from those foods as well. So this simple intervention provided an opportunity to expand the palette of the families we were working with, which then changed the purchasing patterns as well. When they would go to the grocery store and, little Johnny would tug on daddy's on pant leg and he would say, Daddy, can I get that food over there, that those collars over there, that the kale over there, the whatever over there? And initially he would look at his son and he would say, Son, there's no way. Subconsciously, he wouldn't tell him to his face, we're not getting that. But he would say that because why? He knew that if he bought those, his child may not eat them. But now he knows if he buys them, he knows how to prepare them now. He knows he's going to consume them. He knows it's not a waste of money. And he knows how it made him feel, the health benefits that came from that. And also, he started to talk about his blood pressure management had improved and his diabetes control had improved. I mean, the list goes on and on. But this is a simple intervention that we were able to practice and put in place. I think that it's important for us to think through this lens here. Food as medicine has to be a priority for us all. Cardiovascular diseases, diet-related chronic conditions affect all of us, no matter your income level. It affects all of us, no matter your age. And if we lean into this using high-quality evidence-based tools, we can improve health outcomes for individuals, improve satisfaction in individuals' experiences, and overall move the needle on health in this country. I want to thank you all for your time, and I'll pause there. I only have a few minutes for questions, but happy to take them.
All right. Thank you so much, Dr. Kofi, for such an insightful information. I'm looking at the Q&A. I don't see any question, but if anybody has a question, if you can raise your hand, we can allow you to ask your question.
I see one of our collaborators at AmeriGroup DC, Jasmine, talking about our collaboration. Great to see you on here, Jasmine.
Any questions for Dr. Kofi? This information was very important. The connection with the food as medicine, the prevention part, the treatment part. I see no question, but thank you for an amazing and educational presentation. A lot to think about. Laura Long, thank you, Laura, for that comment. I agree. There's a lot to think about. These studies, the case studies that you show, and I didn't even know this program existed at Children. So happy to hear that there are some great work happening already in the community. But we do have a few folks, of course, that are from hospitals. The one question that I probably will ask is, what are some suggestions for next step that you would have after someone hear this information? What is something that they can do to start making some moves?
Yeah, great question. So I'm passionate about this, and you're hopefully you can hear that passion. But the first question people are asking is, who's going to pay for this, right? So I think you need to understand that first and foremost, there's a lot going into these kind of interventions. You're seeing a lot of federal government positioning and posturing to open up doors to allow us to think about how we can better address health-related social needs. And so thinking about that is critically important. You can see there's a ton of papers that have been out that are showing how you can use interesting waivers. Local payers are using interesting waivers to pay for some of these services and create value-based payments with healthcare systems and payers to be able to move forward a lot of these interventions, whether you're screening for food insecurity, whether you're addressing food insecurity, nutrition security, whether you're being more creative with looking at health-related social needs and thinking about how that influences health outcomes as well. So there's funding that's going to be positioned, that's going to hopefully open up in the coming years to be able to position better for this. I would say think about doing pilots with small groups of your clinics or small clinical practices, getting champions who are on board. See what you see, because when you see it, you can't unsee it. You begin to realize that your members, your patients, your families are benefiting from it. They express that. The satisfaction increases. It goes alongside what else they're getting. I'm not eliminating the role of medicines. Medicines are hugely beneficial as well. You can see how these kind of things, they can be adjuncts and support each other as well. And this is just something that I would say is a great place to start.
Awesome. Thank you so much. I see we have a question here from, I hope I say your name correctly, Cleodna McFadden. She's a social work at MedStar Washington Hospital Center. Thank you for this question. How can we get people connected to 4P Food Flip RX?
Great question. So there are a lot of ways through Children's to do that. I can put in the chat a individual who's we have two principal investigators at Children's, Dr. Laura Fisher and Dr. Kadira Ali at Children's National. For Children's National, L. Fisher, LFISCHER at childrensnational.org. She's a leader you can talk to, or Q, I think it's Q Huff, QHUFF at childrensnational.org. That's another person you can talk to. You can reach out to me as well. I'm happy to connect you to them. So please follow with me if you're interested in getting connected to them. And again, there are so many different ways of doing these kind of interventions. That's just one example. There's so many more that would love to share with you all as well.
All right. Well, I'm not seeing any other questions, and we actually at time. Dr. Kofi, I truly appreciate your sacrificing your time this afternoon to come and present to us. Appreciate the information that you shared with us all. Everyone, have a wonderful afternoon. Please keep a lookout for additional webinars that we'll be hosting in the near future. Thank you, everyone. Have a good afternoon.
Take care.
Bye-bye.